communities. So GTAL is a Media and Communications Manager at the New South Wales Multicultural Health Communications Service. And she's been working for 10 years in comms and marketing, specialising in health communication with CALD communities. Her work involves developing communication strategy and delivering evidence-based, insight-driven communications projects and campaigns to effectively communicate with CALD communities. So that's G. And then the second speaker is Reema Naresh, who is Principal Project Officer at the Australian Women and Girls Health Research Centre at UQ. And she's worked in consumer and community engagement in the health sector. And before that was with Queensland Health with a multicultural health promotion initiative called the Good Start Programme. So she's worked a lot in the multicultural sector in Australia, New Zealand, Fiji, and the USA. And she's passionate about community involvement in healthcare design, development, and research. So, thanks for recording, Karen. Some people can't make this session, so we will just share a recording to the closed group. It won't be public. But for those who are here today, please feel free to ask questions either in the chat, or there'll be loads of time for questions afterwards. So we're really aiming for this to be an interactive session. So think of your questions as we go. But we'll start off with G.
Hello, everyone. Very nice to meet you. So it is a great pleasure to be able to talk to you. I know half of you are probably communications professionals and half of you are health researchers. I'm really pleased to have this opportunity to talk to you all about top level principles and concept when it comes to engaging and communicating with people from culturally and linguistically diverse communities. I'm just going to share my screen. If you can see it, or
we could, and then it's moved on to the other screen. So I think move it back to where it was.
Yes. How about this?
That's it. Yeah.
Right. Okay. So today I'm going to talk about communicating and engaging with culturally and linguistically diverse communities, and just a little bit about myself. I moved to Australia 10 years ago. Originally from China as an international student. And I studied strategic public relations at University of Sydney. And then after graduation, I was lucky enough to start working with a specialist communications agency in CALD communication and engagement. A few years later, I moved on to health sector, and I worked for a medical college and for their media and communications work. And now here I am really trying to help the New South Wales Health communicating and engaging with CALD communities here, specifically in New South Wales. So I really appreciate your interest in talking to this community. And so I will just give you a quick snapshot of the cultural diversity in New South Wales. I think that's why it all brought us together today, to really zoom in to look at this specific community. So I'm not sure, what in the audience, we may all have different levels of knowledge in this area, but I will start with just some numbers. So according to the
G, this is Reema. Sweetheart, your display settings is showing us all of your presenter slides as well. So if you want to just drop down to the display setting and make it, that one, and then that one. I think that should.
Oh, this is much better.
Wonderful.
Sorry, technology is not really my friend. I say this a lot. So 1 in 4 New South Wales households speak a language other than English at home. And also more than 2.3 million people in New South Wales were born in more than 300 other countries, not in Australia. And half of New South Wales residents have at least one of their parents born overseas. So now you probably get an idea about how diverse it is in our state. And so it is imperative to understand this community and also knowing a little bit of the approach when it comes to talk to this specific community. They are large in size and they come with their own cultural characteristics, and of course it comes with their own challenges as well. So today I'm just gonna talk about 3 parts. Hopefully it gives you a rough idea about understanding this specific audience, and also what are the appropriate approach when we come to talk to them, and some successful case study for your reference. And also at last, I will just talk very quickly about New South Wales Multicultural Health Communication Service, so about us. So I'm just gonna start the first section. So there are a lot of cultural nuances in communicating and engaging with multicultural audience. So the very first step is to understand your audience, where they are, who they are, and even their stories. So that shaped their behavior and their way of understanding the Australian society, and also accessing a lot of services, settling in a new country. So I'll just start with a few questions. Do you know what language is most spoken in New South Wales other than English? I can't really see you, so you can unmute yourself and have a quick answer if you can.
Would it be Cantonese?
Good guess. Any other response from the room?
Mandarin?
Yes, actually it is Mandarin. So the latest ABS census actually reveals that Mandarin is the most spoken language other than English in New South Wales. Next question, what are top 5 language groups in New South Wales? Now you can go a little bit broader. Any?
Vietnamese?
Vietnamese, yes. That's one.
Arabic?
Yes,
Hindi?
correct. Hindi, yes.
Hindi, yeah.
You're getting there. That's 3.
Arabic?
Punjabi?
No. All right, I'm gonna reveal the answer. So it is Mandarin, Arabic, Cantonese, Vietnamese, and Hindi. So now we all know that our state is such a culturally, linguistically diverse place. So I would say that if you want to really understand your audience and take a look at them, and then the very good starting point is ABS census data. So every 4 or 5 years, the ABS will conduct its census across the country. And then the latest data that we have is the 2021 data. So it provides a really good tool called to give us a snapshot of the size of a population by language, where they are, and then they have a really good tool called Table Builder. So if you go onto their website, and then you can see that's one of their a tool and resource that you can, have a click through. And I believe that registering as a user of Table Builder is free, and then you can start playing around to find the data that you need. So the second step may be some of you are researchers and you do a lot of research projects, and so those data can come in really handy. You can overlay those data with ABS census data and then get a little bit more insights into this particular audience that you want to reach. And the third one, I would say, some insights. So don't forget to have a chat with the community members. And if you want to reach out to Arabic speaking community and Chinese community and have a conversation with them, and just like you do your research, you have the quantitative part, you also have the qualitative part where you can really have those conversations started to understand their behaviors in terms of media consumption, their community attitudes. So all those insights will really help you to identify who your audiences are, where they are, and what's their mindset and approaches in terms of a certain subject matter. And particularly in the insights section, we also have a lot of really useful tools for you. So now, I really can't help to talk about health literacy. So health literacy refers to a person's ability to find, understand, and use information to make decisions about their health. And you have to understand that when people migrate from overseas, and they may have a very different understanding of, for example, how the health system works. And it can be simple questions, simple things for you, but it may not be that straightforward for people who from a migrant background in terms of navigating the services, how the society, the system is set up. So when it comes to the health topic, they may have a very different understanding of the health, how the health system works here. So if you can go and have a look at this resource that we have developed. So it's called Developing Health Resources for People from Refugee Backgrounds, even though it's specific to people from refugee backgrounds, but it is actually quite useful across people from CALD communities as well. There are a lot of principles that you should be considered from the very beginning of your communications, collateral development, and also resource as well. Also when we're thinking about help people overcome the health literacy. And we also recommend that you think about the channels and when it comes to developing resources, we want to make sure that resources are culturally appropriate and really talk to them. So when you're developing your messages, and think about using plain English and avoid jargons. Use maybe graphics and visuals more than written language. For example, a lot of people from refugee backgrounds, they haven't had access to schooling. So when we develop resources for them, we may want to use visuals. For example, develop a short video for them rather than a flyer with a lot of written messages on it. And then next one you may want to consider is translation, because people from CALD communities speak a lot of different languages. And when you have those messages translated in their languages, then it really goes to their mind, really goes to their heart. So it's easy for them to get the message. Now, also a little tips for you is to consider their media consumption behaviors to determine the best format of your content. So, for example, the Chinese community is big. And when I ask the questions, what is the most spoken language in New South Wales other than English? And I heard Cantonese as a first response. And it is very true, probably for a very long time, because the Chinese community is huge in New South Wales. They're probably the top one CALD community in by the size of the population. But for a very long time, the Chinese community also has quite a lot of changes in itself, because in recent years, the migration actually determined that a lot of Chinese community members are migrated from mainland China, which means a lot of them speak Cantonese. So the Cantonese-speaking communities within the Chinese community are more well established, and they probably have a slightly higher English language proficiency as well. So when we are, for example, thinking about engaging and communicating with the Chinese community, and maybe these features will have to be considered as well. So now coming back to translation, when and also their media consumption behaviors, it means that it's really helpful if you can understand what media they're consuming. A lot of Chinese community members may consume WeChat a lot, and a lot of community members from Indian background may be highly digitally savvy on digital media. And also, for example, some older demographics within a certain community would still consume a lot of print media. So when we look at this particular community, you really cannot just adopt a one-fits-all kind of approach. So there are a lot of nuances in communicating with this specific audience. So I would highly recommend that if you're interested, and you can also go to this newly published resource called Multicultural Communications Playbook, recently published by Multicultural New South Wales. And it touched, in that resource, it actually unpacked a lot of top-level concepts that I have mentioned today. So it is longer, but it is well designed and very helpful when you want to understand the audience, developing resources, choosing your channels, and also deliver your campaign, and even evaluating your campaign results as well. So that's a really helpful resource if you're interested. Now, I just want to stress that within New South Wales Health, we have a very strong policy that mandates health organisation and staff should not use apps or other online machine translation services such as Google Translate. So we have to use human translations. And I will come back to this translation process a little bit later. And also we have a strong position on machine translation, as nowadays, you know, that AI technology has advanced so much. Now, I just give you a quick case study, and then to showcase how effectively communicating with CALD communities. So I like to just talk about Multicultural Health Communication Service and New South Wales Health collaboration on the pandemic response. So during the pandemic period, and we feel that so back then we felt that the multicultural communities was very much left behind in terms of acquiring information about COVID-19, and also as well as the government rules and regulations, because it was changing almost every day. Then this is a big, large-scale across government campaign. So it has multiple elements and components to it. So one is a collaboration with Multicultural New South Wales, Department of Customer Service, and a lot of other local health districts. So we work very closely together to develop COVID-19 translated resources for CALD communities. And another component of it is a direct engagement with religious and community leaders to share information through their networks. It also included outreach work by the local health districts, ensuring that the bilingual support workers and staff at COVID-19 testing and vaccination clinics, there is enough staffing to help people on the ground. We also hosted multicultural online media forums with 2,500 leading representatives of religious and community groups and bodies, making sure that those information really funnel through them into the communities. And we also developed an online video series in multiple languages. So you can see that we engaged so many community leaders and GPs from multiple different cultural backgrounds to deliver those important vaccination messages in their languages to the communities. It has received a really good outcome because as a community member, in the Chinese community, I saw one of those videos and in Chinese. So it really, I believe that other people, community members from other communities also have come across these videos. So that is just one of the campaigns where Multicultural Health Communication Service have joined and played an important role in terms of supporting the campaign and really getting the campaign messages through to the community. So last, just about us. So we're a statewide health communication service and we're hosted by Southeastern Sydney Local Health District. And our role is to strengthen the capacity of the health services and programs to effectively and appropriately communicate with people from CALD backgrounds. And we also coordinate provision of multilingual health information. If you go onto our website, you can find a large, wide range of health information and resources in all different languages. So what do we do at Multicultural Health Communication Service? And then, so here are our main areas of work. So we develop resources in language, and we also sometimes consult with community members to help shape and develop communications campaigns. And we have a really good networks with our communities and also multicultural media outlets. And we also deliver research and campaign evaluation as well. So that's basically what we do at the Multicultural Health Communication Service. So in terms of translation, and we also have a really rigid translation process to go through, ensuring the highest quality of the translation for the communications collaterals, resources, campaign assets, and because it is a key step and sometimes determines the success of a communication project. So And every fortnightly, if you're aware or not, we host a multicultural media online conference. It is considered as a trusted source for public health information and among the multicultural media and community. So every fortnightly Wednesday afternoon, there will be half an hour hosted by our director, Jasusa Halaratni. And the conference usually hosts 1 to 2 health professionals as guest speakers to discuss important health issues relevant to the CALD communities. So every September, we do Multicultural Health Week as well, and it is celebrated across New South Wales in the first week of September each year. So the aim is to raise awareness of health issues experienced by the CALD community. So through the Multicultural Media Health Week, we aim to address a lot of issues and challenges that the community experience and face. So we'd love to have you join us for this year's Multicultural Health Week, and the theme is about healthy eating. So we're very excited to deliver this year's Multicultural Health Week, and really happy to have your support or being part of it or get involved. So if you're interested, let me know, and I'll definitely keep you updated about this year's Multicultural Health Week. So that is everything I want to share today, but like I said, I don't know your level of understanding and knowledge in this space. I you know, I may go too broad or too top level, or you know, if you have any questions, and please do ask, or I'm happy to pass on to my fellow guest speaker. Thank you.
Does anybody have any immediate, I mean, I've got a whole list of questions I'd like to ask, and I'd like to get to Rima, but if anybody's got anything specific to that presentation that they'd like to check now, put up your hands. I just wanted to ask, G, with those resources and everything, they're for New South Wales, and obviously there's a lot of people from other states on the call. They'd still all be relevant for wherever you are in Australia, I assume, wouldn't they?
Yes, yes.
Cool. Anyone else? Okay, well, we might, so save your questions for the end. We might move on to Rima. So over to you.
Hi, everyone. I am going to attempt to share my slides, and let me know what you get to view. Share. That is not in presentation mode. So can you see my slides?
Yes, that's perfect.
Okay. To have it in some sort of mode so I can see what I'm showing and you together. So is that still working?
Yep, that's just your main.
Loading.
Yeah, that's your main slide,
Okay.
I think.
Great. Okay. So my name's Rima Naresh. I am calling in from Brisbane. So I'd like to acknowledge the traditional owners of this land that I get to call my home, and acknowledge all the different lands that everybody else is calling from. I'm originally from the Fiji Islands, and like Helen was introducing me earlier, I've had the opportunity to live and work in a number of other countries as well, which has given me a very interesting perspective on working across different cultures. So my role here at the Australian Women and Girls Health Research Centre is of a principal project coordinator role, and I was brought in to support the diversification of a longitudinal study. So when the study first started 20 years ago, the population of Australia was very different to what it is now, and G very beautifully articulated that in terms of what it is in New South Wales, and very similar things have happened across lots of other states. And when we look at the census data, we now see that the largest migrant population in Australia now is of Indian background. And then the next one is of Chinese background. So this is the census that just happened in 2012. And so then the longitudinal study that has been running for the 20 years isn't reflecting the population right now. So they tried doing different things. And what they found was the strategies that they explored wasn't quite giving them the results that they needed. So then they brought someone in my capacity. So I'm going to share with you some of the things that we did that worked, and then we'll open up for questions. Does that sound okay? Seeing some nods, that's good. So now I just have to figure out how I can scroll through my files without Monday. If I just, yes, that worked. Okay, great. So our approach has been.
We don't have your next. Did you try and change slides? Because we don't have the next one.
Oh, it didn't do that. Okay. I am going to get Karen to share the slides then, because it's really tricky to share it. Karen, can you do that for me? Have you finished lunch?
Yeah, sure, Rima. I'll just
Stop sharing. I have not managed to stop sharing, have I? Sorry, guys. Just using a little laptop.
Yeah, can you see that now, Rima? I'm sharing. Can you see that?
Can you guys hear me? My system is saying that it's not responding. Okay, I can see Ella's. Okay, Ella's head is nodding. I have the circle of doom happening on my screen right now. So I'm just gonna, so let's go to slide number 2, which I can't see at all. Just give me 1 minute. Just gonna try to open the slides on my end so that I can talk you through it. Just 1 second. So one of the approaches that we had was that one of the approaches that I know works very well is identified recruitment. So my role is what we would call an identified recruited role, where they brought someone from the community to work with the community. And I think this is a very powerful way to work, and it's something that I advocate for very strongly. So in my previous role with Children's Health Queensland with the Good Start program, this is the methodology that was used. Members from the community were recruited, so they were community leaders. Some of them either qualified for the role because they had the educational background, or if they didn't, then they were supported to get the credentials that they needed to be able to do the work. And what it means is that when we bring in people from the community that we're trying to reach, it really eases a lot of clunkiness. So basically you're getting in there with the language, the cultural nuances, and that intel is within the team. And so then the person you've brought in through identified recruitment becomes the bridge between your team and the community. And it really eases a lot of heartache. So in our case, what it meant was I had the language skills. I also had the community connections. I also was very aware of the methodologies and channels, again, that what G spoke about earlier, that would work in community. But in saying that, our multicultural communities or CALD communities are very diverse. So I can't possibly represent every community from India. Every state in India is almost, you could say, like a different country. They have their own language, they have their own spice mix, they have their own way of wearing a sari. So it means that as research teams, as organizations, as communication professionals, when we start working with multicultural communities, we have to accelerate and begin to learn and understand the communities that we work with, and to be really aware of the extent of diversity that is present. So if you talk to a Kenyan person, it doesn't mean that you're sorted for the members of community from Zimbabwe. Like, it won't work. So you have to really think about how you make those connections. The other point in that slide is community engagement first. So one of the reasons why the initial attempts to recruit and diversify for the longitudinal study didn't work was because there was no community engagement on the part of the university or the research center. So when I started going out into community to do this engagement aspect, members of the community were like, oh, there is a research center that looks at women and girls' health research, and and we can participate in health research. So this knowledge isn't present in community. So taking responsibility for educating community from your organization side is really important. And part of that is community engagement, because the community didn't know that there was such a thing as participating in health research, or that there are different health research centers across the university exploring different aspects of health and all sorts of areas that they're researching. I think as migrants, and is that a personal experience for myself as well, when we first immigrate, we are very busy trying to settle in, get to know where we are, get our bearings, get the kids to school, get a car, get transport, get work. All of that becomes quite overwhelming. And so then our focus is on those, if you want to talk about the Maslow's hierarchy of need, on the lower and the bottom two tiers, and hearing any health promotion message, hearing about participating in health research, and all of these things are quite aspirational. So again, as communication professionals and researchers, really thinking about how can you ease the burden on the person you're trying to reach, so that you can actually engage with them. So for example, with the longitudinal study that we're doing, a lot of the participation requires filling out a questionnaire that can be done over a period of time. You can stop and start. The language has been looked at as well, so it's not complicated. A lot of it is tick and flick, so it's quick. There's also funding that was allocated so that when the questionnaire was completed, then the participant, the woman, got a gift voucher. So a recognition or honoring of time of the participant. What we also did was, because engagement hadn't happened, it was really difficult to go out to community and say, hey, participate in health research, because when we begin to work with communities, reciprocity is a really important thing that we need to keep in mind. We can't go and ask for something if we're not willing to give. There has to be an exchange. And often we, as organizations, go and ask and then don't think about what we can do in exchange. So, so giving a voucher, yes, that's a really good thing. But for example, what we're doing as a research center is we're putting up an event that'll happen later on this month, and it's titled "What Your Mama Didn't Tell You: Multicultural Women's Health Information Session." So we've got an OBGYN who's practicing in community right now, who's going to give a keynote, and she will also role model talking, and she's a woman from an Indian background, so she will also role model that it's actually okay to talk about everything below the belt, you know, and she did a fantastic job doing that in an event that I have recently seen her presented. And then we also have a panel which has some of our researchers and also a local mental health professional within the hospital system where the event is happening. And so it's our opportunity to, because what we have as a research center is knowledge. And so we can gift that to the community and help build women's ability to be able to make informed health decisions about whatever aspect they're journeying through. So think about what is it that you can give from your side to create that reciprocity balance. So growing and supporting the relationship between our health centre and the community. So it means also continuing to build a relationship. So it, and this takes time. And whenever you would have worked with Aboriginal and Torres Strait Islander communities, this is something that we've said when in my previous role in consumer and community engagement in the health sector, is that you need to invest time because you can't quickly build trust. Trust is built over time and it's relationships-based work. So if you know that you're going to be wanting to work with diverse communities, then you need to, from the moment you write your project proposal, you need to start investing in building those connections in community. So when it comes to recruitment, when it comes to asking for something, you have the relationship to ask. And you're trusted and you're a known face, and it doesn't take long. Like so I was brought on team in May last year. We did an event in August at the India Day Independence event, and by the time so September, October, so October, November, we were at a couple of events, and we had children as well as women come to us and say, were you at the India Day event? Like they were starting to recognize our banner, our branding, our faces, the shirts we were wearing. And so then it meant that not only did the children bring their mums to the stand, because we always have some kind of engagement activity that drew them to us. So the engagement activity we used at the India Day event was we had henna tattoos. And so it also meant that we had to hold their hand to apply it. So they were a captive audience. So we got to tell them what we wanted to tell them. So there's little tricks you can put into your engagement that will support you connecting with them. And for the children, we, for the Diwali event, my lovely colleague Xiaowen had this idea of building lanterns because for Diwali, lights are really an important aspect. And so whilst it appeared like we were babysitting all the children, what it meant was we had a good monopoly on all the mums at the event because they had to come to us and speak to us. And so then we were able to connect with them. Mm-hmm. So again, we were trusted. And so therefore, we had the children with us as well as the mums coming to us because of the different activities we were working on. Another thing we did was working with the community by developing a reference group within the health centre. So right now we have a, let's go to slide number 4. So this is our reference group, and these are women from, these women are community leaders within their own community. So we also have a diversity of age as well as religious background, as well as different parts of India. So we have North Indian representation, South Indian representation. We have a young person in there. We have a community elder in there, and we also have representation from far North Queensland. And so this advisory group, reference group we have, was quite instrumental in guiding us in how to navigate the different communities we were working with. So it was kind of like a two-prong approach. Identified recruitment, bringing me in as a role, as well as I recruited a reference group because I couldn't possibly know the entire cohort of women that I needed to deal with. So then what we created was a really rich tapestry of channels where we were able to get information from. And then we co-designed what would work in community. So we often throw the word co-design quite loosely and say we've co-designed something. But true co-design means that we've actually involved community members, health consumers right from the inception. So these women in our reference group were instrumental in figuring out what would be the events that they would create in their communities that would work, where they would do it, and how they would bring the women in. And then we would go in as part of that and talk about the research that's happening and why it's important to have multicultural women's voices in health research. So, and then what else did I want to say about this? The other thing that we did was we created a database of women who were interested in health research, because whilst we're recruiting for a very particular cohort of women from very specific age groups, we kept meeting women who didn't match that. And so we had excited them, inspired them about participating in health research, but we didn't have a study they could participate in. So what we did was we created an active database of all women who said, yes, we want to participate in health research. And so now we have a database of about let's go to the next slide. So when I developed these slides for International Women's Day, when I presented it, we had 304 responses. I think we're up to about 350 now, women from diverse backgrounds who said they would love to participate in health research. And this is available across other studies that research projects that would happen on campus for us as well. Let's move on to slide number 6. So some of the key takeaways that we have felt is really important. I will go through that, but I'll also add that because Chinese community was the next Southeast Asian community members were the next group that we wanted to recruit in. When the management and the directorship saw how effective it was bringing an Indian woman to do this work, I very strongly advocated for bringing in Mandarin-speaking staff to support the recruitment of women from Chinese ancestries. And so you can see my colleague there, Jennifer, and another colleague, Li Min, who we actually went to the Chinese New Year event in a very heavily populated Chinese part of Brisbane to do some of this recruitment. And like I said, our presence is important. The more we appeared in community, the more familiar we got, the more trusted we got, the more likely people said yes to us. Tailoring of resources and the way we do things. So the engagement activity I gave you an example of, and any community-facing material, again, G has done a really fab job at just explaining, you know, anything community-facing needs to have everyday language. Translation was something also that was a really interesting experience for us as a team. So I did not need to translate any material that I used, and in a minute I will show you some of the flyers that we developed. But for the Chinese community, we did have to do some translation. And the reason for this, and it's not something that I had even had to think about, but once we started reflecting on this, it became very clear that we need to look at immigration pathways of communities that come here. So for example, a large number of Indian immigrants either came because of education or work, and English as a skill was mandatory, meaning that you had to either demonstrate that you could speak English or sit a test. And for the Chinese community, it wasn't that pathway as much, and that there was investment and business, and so then English wasn't a requirement. So therefore, our Mandarin speaking team members spent some time doing translation so that and making sure that the information was funneled in the appropriate way. But again, it's a longitudinal study. The likelihood that our survey is translated is very low. And so if you think you want to work with a community where your resources will be translated, then really think about, are your instruments going to be translated, and start thinking about that early enough so that it's built, the cost of that is built into your research proposal. Understanding culture and language, she's talked about that. Allowing time, I can't emphasize that enough. I think it's a really important thing to think about and build that in. And reciprocity and relationships, again, I've spoken about. The other aspect that I do want to emphasize is for any any people over here who are doing research, is to think about, and I think now you can't even put in a research proposal in without demonstrating that you're involving consumers. Like, it's starting to get mandatory, but think about how you're going to involve consumers in your research. So we're thinking from, and if you have done good community engagement before you've started even thinking and conceptualizing what you're researching, the community will tell you what the needs are. And so then that's really co-designing your research with the community as well, because they're inputting in what the gaps in knowledge are and what needs to be explored and researched. I'm working with a genomics research project, and they are developing a framework to work with South Asian populations where, because they haven't done genomics research in that population, and there are taboos around different community groups around giving body or blood samples. And like, our research is a survey, but then there are lots of other forms of research where there would be requirements that would need different approaches in community. So how do you break those barriers? So those team members have been really present in a lot of community events, and they have invested time in educating the South Asian populations and community leaders about what it means to participate in genomics research and what it would mean for the community. So when I've spoken to women in our community, we've really taken the angle that your participation in this longitudinal study means that you are going to be able to impact and influence the health of your daughters, your sisters, the women in your community. So it's kind of reaching out to women and inspiring them to do something like this. Let's move on to the next slide. These are some pictures of our presence in community. So you can see Geeta Mishra, she's the director of our center. She was present with us in quite a lot of the spaces that we were in. We made sure that our booth, our table had culturally appropriate and familiar material and colors. Next slide. This is the event where we were with the children, where we were doing crafts. Our branding and color became quite familiar with a lot of the community members. And yeah, and then I think the next slide is also just more pictures of our events. So that is all of the things I wanted to talk about. Hopefully that was useful. I still have the wheel swinging around, so can someone just give me a nod that you can actually hear and see me?
Yeah, that was
Okay.
fantastic. Thank you so much. Now we've nearly run out of time for questions, which is such a shame because I've got so many, but we've got a couple in the chat. So these are, so either G or Rima, whoever would like to answer. So the first one, how important is it for public health messaging to be delivered by people from the same cultural background as the audience to communicate credibility and trust? Is for the community, is it about seeing someone they can identify with, or having someone in authority like a GP or someone from a health department? Who would like to? G, maybe you go?
Yeah, I'm happy to take this one. Thanks for the question. So it is important, to put it simply, but I would say that the idea is that we would like to leverage the authoritative voice of, for example, a GP to deliver health messages to the community. So, for example, I'm currently supporting the delivery of the winter flu vaccination campaign for New South Wales Health, and our research did reveal that a lot of community members from the CALD background actually respect their JPs and trust them a lot. So they have a very strong reliance on their JPs' advice when it comes to their health and well-being issues. So then one of the campaign tactics is to film the JPs from the target CALD communities to deliver those messages, encourage vaccination in their languages. And then we're currently working on those videos, finalizing them, and hopefully we'll leverage our community connections and networks to disseminate those wonderful videos.
Thank you.
I hope that answers your question.
I can add to that by saying that it also really depends on what the messaging is about. So, for example, vaccinations in like some communities, yes, doctors are very much important in delivering that. But then there might be other things in terms of, for example, breastfeeding. It might be much more nuanced if a mother who was really experienced in breastfeeding from that community spoke about it and shared information. So it's, again, really understanding who you're trying to reach and asking those community members and community leaders what would work for their community. So always getting that answer from within the community before you formulate your response or come up with some awesome strategy that would work.
Thank you. Another question about the timing to get translations done. How long would you allow, especially if you need to translate into multiple languages?
So it really depends, and depends on how many languages, the number of languages you want to translate your materials into, and also the format of that particular piece of material. For example, if it's a video and we need to translate it, need to subtitle the videos, and then that might take longer. And if it is a piece of artwork, then it involves formatting and checking, proofreading again after the translated text laid into the artwork. So a lot of factors actually plays a role in the turnaround of any piece of translation, but just a top line idea, for example, a Word document may take can turn around quite quickly within a few days. And sometimes it's also about the language you're after, for example, if it's a rare language, and then the pool of the translators, especially the qualified translators, are very small. So then it takes longer for them to turn around a particular piece of translation. But for really popular language like Chinese, Arabic, usually we have an ample supply of translators. So usually that can turn around quite quickly. So that's my response to your question.
And can I just ask, so for the, oh, sorry, you go, Rima.
I was just going to add that, again, I caution that we don't always want to just think about and go to translation straight away, because, for example, with the Indian community, we didn't need to do that at all. You know, the women that I work with have at a minimum 3 degrees or 2 higher degrees. So language wasn't an issue. So really, again, understanding who the group is, and also think about the original language document you want translated. Make sure that you start off with a document that is already in simple English. And then also, once it's translated, make sure you give it to a community member and see if it actually test it out. It actually communicates what it needs to. So have it retranslated back. Because I remember picking up an NDIS document and reading it, and it was so complex that the heaviness of the language meant that I actually didn't want to read it. And so then the money that was invested in the translation was wasted. And sometimes, like what G said, it's actually a lot quicker to hold the phone in front of a community leader and get them to just say it. It's quicker, and because a lot of the spoken language is quite different to how it's written, and it's very formal. So check all of those things out as well.
Thank you so
Yeah,
much.
I do echo that. There are a lot of nuances, so understanding your target audience is the very first step. And in the ABS census data, the table builder, you can actually filter the filter it by English language proficiency. So you can say that the Indian community has a really high English language proficiency, probably sitting at 97%. But when it comes to Chinese and Arabic and English language proficiency, it's much lower, probably sitting around 25%.
Thank you so much. We've run out of time, which is such a bummer because I've got so many more questions, but I think we better leave it there. Thank you so much to both of you. That was absolutely eye-opening and really brilliant. We've got various resources that we'll share in a follow-up email as well as the recording. So it's not for the public, but if there's anybody else in your CRE who would find this useful, feel free to let them have it. But thank you so much to G and Rima for a wonderful, wonderful session. Really appreciate it.
You're very welcome. Helen, what
Thank
I
you.
could do is I have a little bit of time right now. So if you want to just throw some questions at me and we just keep recording. And G, if you have a couple of moments, we can just address them so it's recorded and then it becomes a little bit of a resource later.
Oh, sure. That's a great idea. Yes, if anybody has questions and has time to stay on, that would be wonderful.
Or even what's in the chat thread. And if you want to read it out to us, we can explore that.
Yeah, sure. Thank you. So by those who have to go now, I just had a really quick one about, so when you're translating into different languages, given that some people may speak multiple languages, does the messaging substantively change, and does that matter? So if you're reframing health messaging for one language group, might you end up with a product that's really different for a different language group, and does that matter? So G, do you change the actual messaging, or is it just the language that you change, kind of thing? And if you change the messaging, how?
As far as my experience goes, I don't say the messages have drastically changed.
Okay.
Normally, all we do is we tailor it to suit a certain channel and certain audience and really talk to them. So I would say that tailoring is very much used for this type of work. Yeah.
I'm not an expert in this, but what I would say is that, again, because there are so many nuances, whatever is translated, you need to test it out in community to make sure that the message is actually what you're trying to communicate, and then put it out to public. So I think, and that to me signals that you need to allow time. But in saying that, I know that during COVID, because, like when we talk about systems change and processes in bureaucratic large organizations like university, health and government sector, we say everything takes time. But we have seen during COVID that we can move rapidly and fast. So I don't actually, as a health consumer representative, when I do work outside of my role in giving advice to government from a lived experience, I don't take it as an excuse. I do say that, well, actually, I have seen you work fast, so I know it's possible. So anyway, I just thought I'd throw that in there because we have seen it work.
Here is an example. So a few years ago, there was a federal health campaign addressing mental health issues during the pandemic period. And obviously, there is a campaign targeting the general population and also the CALD communities as well. But the concept and the key messages for that mental health campaign is actually called How's Your Head Today, if you come across that campaign. So when we take that campaign to tailor it to suit the CALD community, we actually change that tagline to how are you feeling today? Because one, it's very hard for the translator to translate that concept into different languages. So that's why I come back to stress the importance of using plain English. So for example, feeling blue may not be very easy to translate into multiple languages. So we might as well be straightforward to say feeling unwell or feeling sad, to be specific. So that's the little bit alteration that we did for the CALD component of that campaign, even though the mainstream general population campaign still used very widely the tagline that goes, "How's your head today?"
Oh, thank you. That's a great example. And any other questions from anybody on the
I just wanted to say thank you. It was lovely. It was really fascinating and interesting. And yeah, we wish we had more time to ask lots more questions. It's more a comment than a question as well. I was just thinking a lot of the principles seem not only like best practice communication principles, but that also like accessibility principles, good practice accessibility principles. And does that, do you work at all across people with disability or disability agencies as well? Because I just see the principles, you know, would be beneficial for not only communities, diverse communities, but communities with living with disability. It was just really a comment and see if you'd worked in that space or if you'd worked with colleagues in that area.
I do see the overlapping area. Overlapping area between communicating with CALD, people from CALD background, and also accessibility. So at New South Wales Health, there is a accessibility team that is looking after that aspect of all the communications. So we sometimes work together if it's particularly for the CALD community.
Yeah, no, that's fantastic, because it's so helpful to have these conversations and discussions about, the principles. And go back to the principles of plain English. It's really, it's lovely to hear that.
I probably want to add there, so when she was presenting, she talked about health literacy. And often what happens is organizations want to increase the health literacy of community members. And actually, it's a two-way approach. It's not always putting the responsibility on health consumers and community members and increasing their health literacy, but it's actually looking around yourself as an organization and looking at the health literacy environment you are creating. So hospitals, for example, in hospitals, like I've worked with health consumers where they've said, why do they call it orthopedics? Why don't they just call it bone health? Why do they call it oncology? Why don't they just call it cancer services? So it's because what happens is, because my background's in health, so I'm using hospital and health service examples. So the hospital is built to suit the clinicians and the staff that work there. It's actually not built for the patients who are there. And that's why they're called patients, because they're required to be patient to be able to navigate that system. And so really, I think, as communication professionals and researchers, thinking and turning that around and realizing what responsibility do we have as professionals to change the environment that we're creating in our organization that impacts, because we put a lot of responsibility on community members, but really we can do lots of things from our end as organizations to ease that burden. I'm a really strong proponent of systems approach, because a lot of the times we do this Band-Aid therapy of, okay, let's translate this, let's nuance this, make it suit, but it needs to be both ways. Organizations need to look at, is there systemic racism in the health system? Is it too complicated? Are we only catering for the clinicians? Are we taking responsibility for the environment we're creating? And are we doing enough community engagement that we're reaching the people we need, so that it's multifactorial? And I know this is not easy work and it's long term, but the more we think about it in the work that we do, the more likely we will effect some kind of change in that sort of space.
Yeah, thank you so much.
How do you raise that, Rima? That's fascinating, because that's, speaks to so many of our challenges here in prevention as well, communicating prevention long-term, hard to visualize. How do you do that at the table, like with, you know, how do you workshop it with other people that don't have that systems understanding?
Again, I think this, like in the work that we've done recently at in this space, and the work I've done in my previous role as an engagement advisor, it's involving consumers from the beginning. So when a group of people meet, always there should be if the end result of whatever you're doing is going to interface the community, someone from the community needs to be at that table, because they become that bridge builder. They also bring in the intel that, oh my God, you guys are planning to build that clinic up on top of the hill. Did you know that there's no bus stop there? And did you know that my auntie can't get there because she's on a wheelchair? Or did you know that there's a busy, like, they will give you that information. And so I think
it's having all those voices at the table from the beginning, embedded from the beginning. Thank you so much. I really appreciate it.
In every state except for South Australia, and unfortunately in Victoria, this is that organisation has folded, but there are, so for example, in Queensland, we have Health Consumers Queensland, and I think in New South Wales, so there's a consumer peak body. And what we're seeing now is that there's more and more consumer involvement in research, and all the health translational organizations across the country are also starting to talk about that. So there are organizations that are looking and catering to this. And I think people like myself, because I've gone across sectors, I'm bringing that knowledge, because we do love to work in silos. And I think it starts from an education perspective. So here at UQ, what's happening is the Faculty of Medicine is now merging with the Faculty of Health and Behavioural Science and Oral Health. And so now we're not siloing the body and mental health, we're just trying to bring them together. So hopefully in a decade's time, we'll start having that really holistic perspective.
Lovely. Now, better let G go and Rima go, but thank you. I think we'll end it there. But thank you so much. That's been really brilliant. And we'll share the resources and send you a copy of the recording. But really appreciate your help. Thank you, both of you.
Thank you, everyone.
Thank you.
Thanks.
Bye.
Bye.
Thank you. Bye.